Hello, we are live. I hope you can tune in. Once you are in, please let me know in the chat your name. This helps to bring a little bit more interaction. Hi, Lucas. So, if you are watching right now, please let us know your name. We will begin in 4 minutes. Okay, so I propose to start. If anyone is in here, please let us know your name once again, and we will start. Okay, so today we are going to talk about neurology and psychiatry alongside bacteriology and virology. Firstly, we have a weekly newsletter that takes place each Friday. It contains a free summary sheet for USMLE and for the clinical rotations. If you want to receive this free newsletter, then send an email to medicalperspectiveblog@gmail.com. So, instead of starting with neurology and psychiatry, I found a question that is a really interesting question in the NBMEs that can give us a lot of difficulties. So, on this slide we have variable decelerations. This is one of the NBME type questions seen for the OBGYN, and the question that I'm talking about was asking if the variable deceleration was caused by an umbilical cord prolapse or by a compression. How the question actually asks how we differentiate between these two, because both of them cause variable decelerations. Now, the question stem was stating that the female had a gush of fluid and then presented to the ED. Therefore, the female that had this monitoring, the fetal heart rate monitoring, and the fetus had an umbilical cord prolapse or an umbilical cord compression. Please let me know by voting in the poll. Okay, so we have as answer an umbilical cord compression. Now, the key difference between the prolapse and compression is the fact that an umbilical cord prolapse occurs after the rupture of membranes. This is marked in the question stem as the gush of fluid. If the female had the gush of fluid, then we suspect that the variable deceleration is caused by umbilical cord prolapse. On the other hand, if the female had the variable decelerations before the rupture of membranes, so the gush of fluid, then we suspect an umbilical cord compression. Okay, on to the next one. Now, we have a patient of 19 years old that was previously diagnosed with partial seizures. He started treatment 4 weeks ago. However, in the last 2 weeks, he developed a severe cough with purulent sputum. On labs, there are decreased white blood cells, a decrease in the red blood cell count, and a decrease in the platelet count. Moreover, the CRP and the SR have extremely high values. The physician orders a bone marrow tap. It shows histiocytosis. What is the medication used to treat his seizures? Carbamazepine, phenytoin, lamotrigine, or valproate? Please let me know your answers in the chat box. Okay, we have lamotrigine. Do we have other answers for this question? So we have an A. Okay. Do we have other answers? So we have a granulocytosis caused by carbamazepine. Okay, let's go to the next step in the vignette that states that the medication is changed. After 3 months, the patient comes back with a yellow-brown tint on his skin. Now, the CBC shows a macrocytic anemia. Which was the drug that substituted the previous one? Carbamazepine, phenytoin, lamotrigine, or valproate? Hi, Dr. 1. We are pleased to see you. You say lamotrigine for the first question. Okay. What Dr. 1 and Lucas think about the second step in treating this patient? Please, if you are attending and if you didn't write anything, let me know by giving an answer in the chat box to the question. So up until now we have 2 phenytoins. Great. So let's see how we have to interact with these questions on USMLE. The answers were firstly C, and the second one indeed was phenytoin. So the first drug the patient had was lamotrigine, and the second one was phenytoin. Here we have some side effects of some of the antiepileptics. For carbamazepine, we usually see agranulocytosis and aplastic anemia, which we screen regularly with CBC. This has to be balanced with the treatment for epilepsies with lamotrigine. Hemophagocytic lymphohistiocytosis has also agranulocytosis and pancytopenia. However, there is an infiltration with histiocytes on the bone marrow. In actuality, hemophagocytic lymphohistiocytosis is a black box label for lamotrigine. Going back to carbamazepine, we can also see diplopia and ataxia. But more commonly, the questions on USMLE are on the effect of SEADH, a patient that comes with hyponatremia being treated for epilepsy, or they go for the induction of P150. This means that, for example, the patient is an asthmatic or a patient with COPD, and he's on theophylline, and out of nowhere he develops cardiotoxicity, and they ask you ask you why theophylline is inefficient, not why he's cardiotoxic. Okay, one of the instances, of USMLE questions and scenarios can be a female with shock-like pain that initiates treatment and presents further down the line with fever and neutrophil count less than 500. This is clearly a sign of neutropenic fever due to agranulocytosis. This agranulocytosis is caused secondary to carbamazepine, which can also be used not only as an antiepileptic but also for trigeminal neuralgia. Is everything clear on carbamazepine? Please let me know in the chat box. Okay, so on to phenytoin. Phenytoin is usually marked in the NBME questions by hirsutism in large gums. Also, the questions target the induction of P150. A less known side effect is the yellow-brown skin development and the nystagmus. This is why the patient developed the yellow-brown skin in our second question stem. Another important side effect is osteopenia. This is important because it can be differential in a female that has 65 years old and is on antiepileptic drugs. A differential between osteoporosis and osteopenia induced by phenytoin. And lastly, it induces inhibition of folate absorption, so you might have a patient that presents with microcytic anemia. One clinical scenario that can be seen on the NBMEs is a patient that presents with hirsutism and bleeding of large gums after being treated for a resistant status epilepticus. Normally, status epilepticus is treated with benzodiazepines such as diazepam, but if it fails, then phosphophenytoin is used. Okay, the next one used for partial seizures to complex seizure to general seizures is valproate. Valproate has an important effect by causing pancreatitis. Also, in the question stems, patients might develop obesity or hepatotoxicity. Rarely they can develop alopecia. An important effect of the valproate, also tested, is inhibition of P150. Now, when the patient takes theophylline, we'll have an increase in the concentration of theophylline, leading to cardiotoxicity and to a sympathetic effect. In comparison, carbamazepine will lead to a decrease in the theophyline's effect. One example of a clinical scenario is a teenager that develops flexions and extensions of his arm upon awakening. These are called juvenile myoclonic seizures. After treatment, he complains of epigastric pain and his amylase is high. This is an instance when we give valproate, and valproate is indicated in juvenile myoclonic seizures. and the patient develops down the line pancreatitis. Okay, do you have any questions until this point? Dr. Juan Lucas? Okay. Sure, we will do the box a little bit bigger. Now, lamotrigine is one of the last antiepileptics we discussed today. It presents with Stevens-Johnson syndrome as a side effect or hemophagocytic lymphohistiocytosis. Another clinical scenario aside from the one that we saw is a child treated for juvenile seizures that also develops a positive Nikolsky sign. The Stevens-Johnson syndrome is a drug-induced skin reaction that is similar to pemphigus vulgaris. Therefore, on stroking the skin, the patient will have those blisters go out. Okay, so if you don't have any questions, Dr. Juan Lucas, please let me know if you have, and if you don't, we can go to the next question. Okay. Now we have a woman of 25 years old that comes to the ED with vomiting and sensitivity to light. On the physical exam, she comes with knuckle rigidity and palmoplantar maculopapular rash. When asked about relationships, the patient says she prefers to focus on her postdoctoral studies. However, 3 months ago, she got into a relationship. An LP is made and the results are pending. Meanwhile, the liver functional tests show elevated transaminases. What is the best next step in treating this patient? We give ceftriaxone with vancomycin, we give ceftriaxone with vancomycin with corticosteroids, we give benzathine penicillin G, or we give doxycycline. So we have a C. Do we have other answers? Okay, so let's discuss the answers. Firstly, ceftriaxone and vancomycin is the standard treatment for meningitis in adults. This ensures a broad spectrum, especially on the most common causes such as Neisseria meningitidis, strep pneumoniae, Haemophilus influenzae. Corticosteroids indeed can be added due to the fact that it improves the rehabilitation phase. Now, the last two, the benzathine penicillin G is given in primary and secondary syphilis, and doxycycline is given only in patients that have an allergy to penicillin in this case. Let's see the answer. The answer is C, benzathine penicillin G. So, when talking about secondary syphilis, we know that it occurs at 4-8 weeks from sexual contact. In that case, we had the new relationship, sorry. On physical exam, the patient will have maculopapular rash on palps and soles, will have generalized lymphadenopathy, low-grade fever, and condyloma lata. Secondary syphilis can also complicate with hepatitis, nephropathy, and meningitis. In this case, our patient developed meningitis. The treatment for syphilis, if it's primary or secondary, is one intramuscular injection of benzathine penicillin G. If the patient is allergic, we give doxycycline for 14 days. However, here we have an exception. The exception is namely pregnancy. If we have a pregnant woman that is allergic to penicillin, then we desensitize the patient to penicillin and then we pursue again with benzathine penicillin G. Please let me know in the chat box if you have any questions regarding syphilis. The diagnosis of syphilis. Okay, so, right. In regards to primary syphilis, the initial step for diagnosis primary syphilis is dark field microscopy from the chancre, the primary chancre. We can also do a VDRL and follow it up with FTA-ABS. In syphilis, it is important to have a screening test, namely VDRL or RPR, that is followed by a confirmatory test, FTA-ABS in this case. So, if the patient underwent a VDRL in a question stem, then we have to confirm it by doing an FTA-ABS. Another important instance is when we have biostats mixed in. Namely, on the question stem we will be asked what is the most sensitive test to diagnose the patient with syphilis. In this case, we have to choose VDRL or RPR due to the fact that they are screening tests. This means that they are highly sensitive but low in specificity. On the other hand, if we are asked how can we confirm that the patient has syphilis, then we have to choose a test that is highly specific but has low sensitivity, such as FTA-ABS. In secondary and tertiary syphilis, we can do a lumbar puncture, and although in the tertiary syphilis dark field microscopy is rarely used, in secondary syphilis we might have Treponema pallidum on the dark field microscopy from the lumbar puncture. Also, VDRL and RPR are used in secondary syphilis. Okay, do you have any other questions? Okay, then let's take a break. For those of you who have not seen the cardiology course, I recommend you to go to the link. I will put it into the chat box if you want to watch it. Also, for those of you who didn't complete the form, please think and consider of writing in the form. This helps improve the quality of the live stream. Okay, now that we took a break, let's go further and discuss this case. We have a 74-year-old patient that comes for an ultrasound to his primary care physician. He had a motor vehicle accident in 1960 and he was transfused 3 units of blood. On the labs, the transaminases are 3 times the normal value. The complement is low and there are purpuric lesions on the thighs. Which is the medication this patient most likely receives? Interferon and ribavirin, sofosbuvir and ribavirin, tenofovir or azithromycin? Okay, so Lucas says this is a hepatitis C. Okay, so indeed the patient has hepatitis C. This is mainly indicated by the fact that he was transfused 3 units before 1980, sorry, when the blood transfusions were not screened for HCV. Not only that we have signs of hepatitis indicated by transaminases that are 3 times the normal value, but also we have signs of porphyria cutanea tarda, the purpuric lesions, and the complement that is low. This is caused by cryoglobulinemia. So the answer is sofosbuvir, and ribavirin. Now, HCV is transmitted parenterally and frequently because of transfusion before the 80s, as we discussed previously. 80% of the cases of HCV infection will become chronic. The treatment is usually represented by two direct antiviral agents, for example, ledipavir and sofosbuvir. Another way of treating HCV is one direct antiviral agent plus ribavirin, as in the question step. Interferon and ribavirin are considered nowadays inefficient. However, they were used before the advent of DAA. The duration for the direct antiviral agents treatment is from 8 to 12 weeks with labs. Okay, are there any questions? No questions. Okay. Then let's go to the last one of this session. So we have an 18-year-old that comes to the ophthalmologist for a consult. His medical history is remarkable for mild schizophrenia. His last psychiatric consult, however, was 20 years ago. Since then, he maintained the same medication he was initially prescribed. On the fundoscopic exam, there is the pigmentation of the retina. Which is the antipsychotic the patient takes? Chlorpromazine, pyridazine, risperidone, or ziprasidone? Okay, so we have a B. Right, correct. Indeed, the patient has pyridazine regimen. Now, can someone tell me what is the difference between the deposits from chlorpromazine and the deposits caused by pyridazine? So what's the difference between pharidazine and chlorpromazine deposits? Can someone tell me in the chat box? So we have one more in the R's, okay? Okay, so chlorpromazine deposits are seen actually in the cornea, whereas pharidazine deposits are seen in the retina. Now, indeed, the answer was B. Let's talk about the side effects of antipsychotics. So, in the case of the first generation, we have high potency, such as haloperidol and flufenazine. The common side effects are neuroleptic malignant syndrome. Patients will present with extrapyramidal symptoms. They can also present with anticholinergic symptoms and QTc prolongation, namely in the haloperidol case. Can you give me the 4 extrapyramidal symptoms that are caused by the first generation antipsychotics and the main 4 anticholinergic symptoms in the chat box? Okay, so then I'll tell them. So for extrapyramidal symptoms, namely we have acute dystonia, akathisia, followed by tardive dyskinesia, and Parkinsonism. Now, in the case of anticholinergic symptoms, the common symptoms are represented by dry skin, by filled by a filled bladder, and by constipation. In the case of low potency antipsychotics, chlorpromazine and pharidazine, we have QTc prolongation plus the same effects but less noisy. In the case of pharidazine, as we discussed, there are retinal deposits, whereas in the case of chlorpromazine there are corneal deposits. Both of them are linked with orthostatic hypotension. Now, in the case of the second generation, there are less extrapyramidal side effects, but we have ziprasidone with QT prolongation. And in the case of risperidone, we will have frequently hyperprolactinemia. The typical case is of a man that experiences impotence due to taking risperidone. For olanzapine and clozapine, we have to take into consideration the fact that they cause metabolic syndrome. Clozapine is a fourth intent treatment, meaning that it is prescribed for resistant psychotic syndromes, and also it causes agranulocytosis. Due to this fact, clozapine requires continuous monitoring. For quetiapine, also we have an indication Parkinson's disease. Quetiapine is chosen in Parkinson's disease due to the fact that it has less dopaminergic blocking effects. And lastly, aripiprazole is a drug that causes less acute dystonia due to the fact that there are a partial dopamine agonist. Okay, do we have any questions here for this question? Okay, so there are no questions. Let's wrap this up. If you'd like more USMLE related content, please subscribe to the channel. Also, if you got value from this course, please recommend it to others. If you know colleagues or students that not only they are interested in USMLE, but also that are interested in applying the medical knowledge. Okay. Otherwise, do we have any questions on neurology, psych in general, or infectious disease? Very clear and to the point. Okay, then Lucas, thank you that you participated to today's session, and see you in the next one in 2 weeks' time. Have a great day.